If you don't have cancer, do GLP-1s change your cancer risk? And then there's bucket number 2, which is, do they change cancer outcomes after diagnosis? Reduce risk of recurrence, survival. And then the third bucket really is, do they interact or enhance possibly cancer therapies, like the actual drugs we're giving, especially immunotherapy?
And identify people who had at least 3 months exposure to GLP-1s versus people who didn't and had underlying liver problems, found a 73% reduction in the development of hepatocellular cancer in people who were exposed to GLP-1 versus those who weren't.
Exactly. I think going back decades when you said retrospective studies, so many of these studies, or if not all of them, retrospective evaluation, we know that diabetes is an inflammatory state, right? And we've all gotten asked, does sugar feed cancer? It's definitely in the top 3 of all questions that we all get as oncologists. There are 3 of us included, but we always say it's so much more complicated than that. It's complicated.
The second thing that I thought was very interesting is that the impact for GLP-1 inhibitors happen in people with viral hepatitis, alcoholic cirrhosis, as well as people with fatty liver.
They say ask your doctor if weight loss is right for you. I have 2 friends who are doctors, and I'm going to ask them about GLP agonists. But first, we're only oncologists in the building, and we're back from the ASCO annual meeting. Guys, how are you recovering?
So the immune system took a hit with the lack of sleep and all of the, friends I met up with, all the data that I took in, but it was so worth it.
Yeah.
I am really happy. I tried a new note-taking tool, not anything fancy AI, but just notes after the meetings that I had. So it's been great to have done that exercise while I was there, and now I actually have my thoughts organized, and I've caught on some sleep. We're 4 days back, so I'm recovered.
I think out of the frying pan into the fire. Truthfully, you're on inpatient service. I think with these conferences, you always miss the recovery for the weekend, and you come back and it's wow, you have pretty much a full work week.
I just think, for the last few years, most of the public conversation has been about weight loss, of course, obesity, cardiovascular risk, kidney disease, fatty liver disease. And now at ASCO, we're seeing more and more oncology data asking a much bigger question. And we've kind of distilled this down into 3 big buckets, right? The first is, if you don't have cancer, do GLP-1s change your cancer risk? And then there's bucket number 2, which is, do they change cancer outcomes after diagnosis? Reduce risk of recurrence, survival. And then the third bucket really is, do they interact or enhance possibly cancer therapies, like the actual drugs we're giving, especially immunotherapy? And so we're going to be getting into that today. Big questions. We don't have, big trial data, but we got some good signal and we want to tell you about it. So Shalon, let's take it away with, do GLP-1s change cancer risk?
So GLP-1s are designed as a diabetes medication, and dozens of abstracts that were presented at the American Society of Clinical Oncology's 2026 annual meeting suggested that this diabetes drug can prevent cancer, and its impact isn't limited to people with diabetes. One of the largest studies that we have is specifically looking at patients with cirrhosis and their risk of developing hepatocellular cancer. People who have cirrhosis can have cirrhosis from a viral infection, from fatty liver, or alcoholism. And in this study, which evaluated 600,000 people in a retrospective analysis, and identified people who had at least 3 months exposure to GLP-1s versus people who didn't and had underlying liver problems, found a 73% reduction in the development of hepatocellular cancer in people who were exposed to GLP-1 versus those who weren't. Now, this is extremely interesting because the headline is striking. The 73% reduction is extraordinary. And for a disease that doesn't have very well validated screening mechanisms, we know that if somebody has inflammation in the liver, if they have early signs of cirrhosis or evidence of liver failure, their chances of developing liver cancer is extremely high. And we always felt that if you're developing liver problems, maybe it's too late to impart any type of modification, and those people are likely to develop cancers without really some type of intervention. The second thing that I thought was very interesting is that the impact for GLP-1 inhibitors happen in people with viral hepatitis, alcoholic cirrhosis, as well as people with fatty liver. pretty consistently, telling us that there may be something that's disease modifying for the process of inflammation, fibrosis, and cirrhosis that we see in the liver, which is preventing those cancers from developing into preventing those livers from developing cancer, which can then eventually be an incurable condition and be a cause of death for a lot of individuals. And the most counterintuitive part is that they saw a fairly large impact in people, not only the folks who had diabetes, but also the folks who didn't have diabetes. So this isn't only from diabetes specific health that we're seeing this impact. Again, there's something about the mechanism that's being imparted by these medications into the mechanism of inflammation in the liver, which is resulting in a lower HCC risk. And when you browse through the 58 abstracts that looked at GLP-1 and cancer at ASCO 2026 and specifically focus on cancer prevention, all of these studies are retrospective studies, but we're seeing a consistent impact. We're seeing a consistent impact across multiple cancers, including colorectal cancer, leukemia, and even breast cancer.
I think the question, though, Shalana, is that I think it's really cool that they saw that HCC benefit across viral, fatty liver, right? Like that alcoholic cirrhosis. That's very, very interesting. But I think the question still, I think, remains, is it the drug itself that is disease modifying, or is it the metabolic benefits that come with losing that weight? Right. Even if you don't have diabetes, obviously, if you lose weight, there's some metabolic benefits. Is that the thing that is modifying the disease rather than the drug itself? And I think that that's a question that will come up over the course of this entire podcast, because I think that's a question that we all have.
Exactly. I think going back decades and as you said, when you said retrospective studies, so many of these studies, or if not all of them, retrospective evaluation, we know that diabetes is an inflammatory state, right? And we've all gotten asked, does sugar feed cancer? It's like, it's definitely in the top three of all questions that we all get as oncologists. There are three of us included. But we always say it's so much more complicated than that, like that. Then it's complicated, as they say. But with weight loss and diabetes and glucose as a fuel, it's a very complicated question. And so I feel like metformin, has been examined as an anti-cancer property treatment for that reason. And GLP agonist I see is like the new metformin when it comes to this. But I think it's going to be a whole lot more complicated as to separating it out with the GLP agonist effects, right? Just reminding ourselves, GLP, glucagon-like peptide, right? So it's exactly a hormone produced in our body that helps release sugar or at least regulate it. But I think your point's really well taken, Shruti. Maybe it's the weight loss that's the part that's crucial here.
And there are statistical things to think about as well. When we do these studies, there's a bias that can be introduced in retrospective studies called the immortal time bias. And we have to be really careful when we're analyzing these exposure and outcome results. And these are not necessarily causal, even though we're seeing a consistent impact in the population exposed to these medications. We're at risk for malignancies. We're seeing a consistent impact, but this isn't really necessarily a cause and effect. And from what I've heard, there is a prospective trial, which is sponsored in part by the National Cancer Institute, to see if this impact for different cancers is identified in a prospective clinical trial. So more to come.
So the theme of these studies is actually pretty consistent to what you were just saying, Shalon, when we move on to patients who've already been diagnosed with cancer. And what we see is that patients with cancer who are on GLP-1s seem to do better. They lived longer, recurred less, had better outcomes during treatment. But of course, if I say that, someone's going to run a headline, Ozempic treats cancer. And that's absolutely not what these studies show. So the biggest broad study looked at a large community oncology cohort across multiple solid tumors. So you have breast, colorectal, lung, liver, prostate, kidney cancer. And GLP-1 use was associated with an improved overall survival. And the hazard ratio was 0.66, which essentially translates to about a 34% lower rate of death. Now, that's a big signal, obviously, and very exciting. But it's also, again, we'll say the word again, we're going to say it multiple times this episode, it's observational. And the issue with observational GLP-1 studies is that patients who are on GLP-1s might be fundamentally different. They might have better access to care. They might be more medically engaged. they may have metabolic disease that's actively being treated, and they may be less cachectic, and maybe well enough that somebody's comfortable prescribing them the GLP-1. And so by virtue of that, we know from independent studies that patients who are not cachectic, who are more medically engaged, who have better access to care, do better. They have better survival. And so I think that really matters when we're talking about this, because a 34% reduction, in lower rate of death is really meaningful. And so we have to be clear about what these studies are actually telling us. So the colorectal cancer data I thought was especially interesting. One study looked at stage 1 to 3 colorectal cancer, found that GLP-1 use after diagnosis was associated with a better 5-year recurrence-free survival and better overall survival. Now, of course, gets my attention. I'm a GI oncologist. But something else to think about is how this relates to the challenge study data, right? So we know data presented at ASCO last year was that patients that are more active have lower risk of recurrence. That was shown in a randomized control trial. And I think that it's important to note that people who also lose weight tend to be able to walk more, get out of the house more. And so I think that it's really important that we account for those things when we're talking about this, because I think the question that's on everybody's mind is, are GLP-1 drugs making people live longer? And now, to be clear, if that is how someone needs to lose weight so that they can be more active, I'm absolutely there. I'm super pro, right? But if somebody is already active and already doesn't have excess fat, doesn't have any metabolic syndromes, those are the people that I think are asking these questions rightfully. And I think that's the part that we really need to get to. What do you guys think about that?
Biochemistry is complicated. As I said earlier, quote, it's complicated. All of it's complicated. But you brought up a metabolic syndrome, right? So this is a recognized thing where it has implication for liver health, so hepatic steatosis. When fat accumulates as we get older, or fat accumulates, and it redistributes in different parts of our body, as I tell patients, in places we don't want it, but especially in metabolic syndrome, where the blood sugar is a little unregulated, it's less controllable. It may or may not include full-blown diabetes, but it certainly has certain implications. And where it intersects with cancer is a little complicated in the sense that whether it causes cancer or certainly increases the risk of cancer, and and how it intersects with GLP agonists, I feel like it's too early to tell for certain in terms of cause and effect.
Absolutely. And I got to say that there was also another study, right? I talked a little bit about the colon cancer studies, but there was a metastatic hormone positive breast cancer study.
Yeah.
Looking at patients that were on endocrine therapy and CDK4/6 inhibitors. And patients who received the GLP-1 had a longer median OS, 67.9 months compared to 49 months. That's a huge difference. And biologically, again, interesting, because hormone receptor positive breast cancer, there's strong links to estrogen signaling, insulin resistance, inflammation. Those are things that come up a lot in ER positive breast cancer. But again, not randomized, right? Unclear, whether this was related to the drug or whether it's related to just, improved metabolic health, which again, it's important. And so I'm very pro these drugs in patients that need them.
The other part to think about when it comes to GLP-1s and cancer is I find it a little odd that we're looking at dozens of studies that are looking at cancer outcome related to one medication, and we're seeing a consistent impact across different cancers. We know in the world of chemotherapy that doesn't really happen, and different cancers have different biology and different response to medications. So I find it suspicious that you have about 8 or 9, I was going through these abstract studies that all are seeing a favorable response with a certain medication. Makes me a little suspicious about the methods, as you've already suggested, Shruti. The second part to really think about is, to your earlier point, whether this is a direct impact of the medication or if this medication is leading to less alcohol consumption, less smoking rates, and if increased activity, and those are leading to better outcomes. Or option number C, does it really matter how these medications are leading to an improvement in cancer? And if we're seeing the cancer and it's you know, A leads to B, that we should take the W.
I want to come back to that breast cancer study, Shruti, that you mentioned. Especially, it's in the hormone-sensitive or hormone-driven variety. It made news in early June around the time of the ASCO annual meeting, and I want to revisit that because it made a lot of news. And that especially is one with the, you know, kind of like the soundbite of that is that taking the GLP agonist, you know, ask your doctor if Wegovy or Ozempic is right for you, but it implies that it has such improvement with outcomes in that type of cancer that the next logical step would be to take it for someone who's not already taking it. But I think that's a really prime example where there's some association that really needs to be dived into a whole lot more, because we think of what is GLP-1 doing? It has implication on hormones, and I'll talk about neuroendocrine tumors in a sense in a minute because there's a link there too. But especially as a hormone-driven cancer, breast cancer, along with prostate cancer, one arguably can say breast is number one because of its prevalence. But if a GLP-1 agonist really remodels how someone's body regulates blood sugar, how fat redistributes throughout the body, and also, especially in women, but also in men, estrogen levels that are produced really have correlation with fat production, right? The more fat we have, our cells will produce estrogen to a greater degree in women than not. And if a cancer that's hormone sensitive is driven by estrogen, then it makes sense that decreasing the amount of fat content, present fat in the body, by a GLP agonist, it makes sense to me that there might be an association, but not yet proven. And I think that's a concern about that. What do you guys think about that?
Absolutely. I actually have never thought about the adipose tissue making estrogen as like that's such a great point, specifically about hormone sensitive breast cancer, that I think is, again, really interesting. And there might be different mechanisms for the different types of cancer. But Jalan, to your point, I agree, right? We know that miracle drugs unfortunately don't exist, right? Of course we wish they did, but usually they don't. The closest thing I think we do have to miracle drugs is improved activity, exercise, metabolic health. And now if this is a surrogate for that, then absolutely, again, some patients might need it. But I agree to be a little skeptical of kind of a miracle pill as much as I want one to exist.
Mm-hmm. Mm-hmm.
Which kind of leads us to kind of another thought about like other abstracts that came out, which there were a few abstracts that came out about how we could use treatment, GLP-1s to enhance the actual drugs that we're giving. Emil, what do you think about that? Take it away.
Yes. So speaking about, in air quotes, miracle drugs, right? So it kind of came out at ASCO again that, a lot of drugs, including the miracle RAS inhibitor that was touted, got a standing ovation, and yet the naysayers will say, but these are not curative, but immunotherapies are. And that's where we say, whoa, hold on a moment, because we know that immunotherapy across the board in metastatic stage 4 cancer cases, it's still relatively an exception to the rule. But whether or not GLP agonists are going to improve the response rates to immunotherapy, really, it's an interesting area of research, and it's definitely not proven. And I think some of these postulations, I guess, made in the abstracts at the ASCO meeting were interesting, but I think